talk about some of the manifestations and what we can do in terms of our limited treatment options for that. The GOLD guidelines for management of COPD recently got updated, and I wanted to go over that. And then with November being Lung Cancer Awareness Month, I thought it would be good to touch on lung cancer screening recommendations and what we do here at Methodist. So in terms of COVID long hauler syndrome, so first we need to define it. So acute infection is acute symptoms lasting up to 4 weeks following onset. Now, a lot of times when I see people in the office who have been recently infected, still with some cough and things, I tell them this could last 6, 8, even 12 weeks post-infection. And when we start getting into those symptoms that last over 2 months, now we're really talking about post-COVID syndrome, long hauler syndrome. There's a bunch of different names out there for it, but the fact is this is all symptoms related to COVID infection. And there's really a wide array of symptoms ranging from respiratory to neurologic, physical symptoms that can persist. There's not a clear definition, not a widely accepted diagnostic criteria, so it makes it a little bit hard to determine how many people are actually having this, what is actually related to COVID. So we're still learning about all this now, 3 years after the initial outbreak. So it's estimated that about 6% of people who had symptomatic COVID will develop at least one of the following symptoms that may last in that post 2-month phase. So persistent fatigue is a common one that we see. Cognitive problems, brain fog is another, and then ongoing respiratory problems, which may manifest in several of different ways. Diving in more into the physical symptoms, so fatigue can be seen in up to 87% of these patients, shortness of breath, chest pain, tightness, cough is very common, cognitive problems, concentration problems, memory problems, and some people, especially those who had severe illness and may have been in the ICU, we may be dealing with symptoms of PTSD and post-ICU syndrome, which I'm not going to dive deeply in today because that's a whole nother topic on itself. So what increases our risk of having these types of problems? Older age, interestingly, female gender, people who are higher BMI, if you have either seasonal or medication allergies, and people who have pre-existing lung conditions are all at increased risk of having post-COVID syndrome. What do we do about it? Well, we try to prevent COVID in the first place. So stressing vaccination, stressing good, hand, eye hygiene during cold and flu months. We just don't get infected. You can't get post-COVID syndrome. Unfortunately, as much as this has spread, most people have now had COVID at least once. So prevalence is certainly there. There does appear to be lower rates of post-COVID syndrome in vaccinated patients. And early, before we had vaccinations and we were dealing with all these post-COVID syndrome people who were coming in, there was actually some evidence that people who had the symptoms and then got vaccinated, their symptoms got significantly better. It was about a third of patients who saw a significant decrease in their symptoms after their first vaccine. So maintaining your vaccination can certainly help. There's a lot of dysfunction that happens in these patients. So most of the studies have focused on hospitalized patients. It's a lot easier to track those. But people who are hospitalized with COVID, only 40% after 30 days are completely independent in their ADLs, which is pretty surprising to me when I saw that number. Only 40% are able to go to normal activities 60 days after discharge from the hospital. And 53% still had limited functional impairment at 4 months. So this is, especially in those who had severe COVID, this is a significant problem. And there's just not a lot of data in children. I'm an adult doctor, so I don't really do any of that. So if you have questions about the children's pulmonary stuff, they're across the street. So when somebody comes into the office, what do we think about in terms of evaluation for these patients? It really depends on their presenting symptoms. So people with persistent respiratory, shortness of breath, cough, You want to think about doing some imaging, either a chest x-ray or a CT scan, looking for signs of fibrosis, especially in severe COVID. We've seen some significant fibrotic disease that has actually led to lung transplant in some people. Consider oximetry walk. So doing a walk in the office, see if their oxygen levels drop, because they would potentially qualify for oxygen. Pulmonary function testing can be helpful, again, screening for fibrotic changes in their diffusion capacity. One thing that I've seen recently is people who had asthma early on, kind of grew out of it, not very symptomatic. They get COVID. Now we've got asthma symptoms that are persistent. And that may show up as some obstruction on your lung function tests. Echocardiogram should be considered as well. Not everybody needs it, but there is definitely evidence of cardiomyopathy related to COVID, so that would be a good evaluation for that. EKG Holter monitoring, looking for any arrhythmias. For people who have significant weakness, you may consider an EMG, cognitive assessment for people who are complaining of memory problems, that sort of thing. And then typically more a problem in the acute phase, but venous thromboembolism should be considered in patients if they've got significant complaints, and that's where duplex ultrasound may come in. So how do we manage these different problems? So in terms of respiratory problems, if they need oxygen, they get oxygen. So if you're less than 88% on room air, either at rest or with activity, you qualify for oxygen. Pulmonary rehab can be very beneficial. And it was, I believe, last year that CMS included post-COVID syndrome as a qualifying diagnosis for pulmonary rehab. So they don't need to have COPD in order to get into pulmonary rehab if they have significant symptoms for over 2 months. One complication that we can see in post-COVID is cryptogenic organizing pneumonia. So that's going to present as these wandering infiltrates on a chest x-ray that kind of come and go. They may get treated as pneumonia, but actually what they need is steroids. And that's usually about a 2 to 3 month course of prednisone. For chronic cough, I tell people to manage their expectations. This is something that's probably going to last for a while. I'm not going to make a huge benefit in it in the short term. It's going to last for months. Things may help, may not. Antitussives can be helpful. Sometimes we'll use inhaled therapies. I usually go straight to like a triple inhaler with a corticosteroid, LAMA and LABA. But it's about a coin flip in terms of if it's going to help those patients or not. And there's no real way to predict it either, unfortunately. So it's really managing expectations, try to treat the symptoms as best we can, and know that the cough should get better with more time. For chest pain, costochondritis, that sort of thing, anti-inflammatories like NSAIDs, sometimes going all the way up to prednisone for more significant cases. And then for people with significant orthostasis, compression stockings can be helpful. So going back to pulmonary rehab, again, COVID-19 with persistent dyspnea is a qualifying diagnosis. So that's all you need to do to submit those patients. They don't need to have a decrease in their FEV1. And if they do get pushback, you can always push back against their insurance carrier because it is an indicated diagnosis and does help. Some specific post-COVID rehab programs in the area are available. Madonna does a very good job, and UNMC has a post-COVID clinic with specialists who focus on this. They have some neurologists, and I believe some pulmonary docs who are doing it, and they've actually done a really good job. So some more information that's out there from the CDC in terms of post-COVID conditions. I've got the hyperlink here if you've got access to that, or if you just Google, there's basically going over these guidelines, so it's available for your review later. Any questions about any of that? We sped through that pretty quickly, but. Sarcoid, not really necessarily connected to COVID. We see a lot of sarcoid. Now, certainly sarcoid is one of those things that can be indolent and then maybe tipped off by an infection, but it's hard to really pinpoint saying, yeah, that's due to COVID. So it's theoretically possible that it could be related to that.
how much difficulty do you have getting patients referred to the outpatient therapy center down there at the med center?
I really haven't had any issue sending them a referral. Now, there may be a little bit of delay in getting them in. Madonna's is mostly focused on just the rehabilitation side of things. But I have not had any significant delays with any referrals over there. And everybody that I've sent either through rehab or through, the Madonna program, they have seen some benefit in terms of their symptoms. But I think the biggest thing is time. And I've had some people who have been coming through my office for, 12, 18 months with persistent symptoms. And it definitely weighs on them. There's definitely a psychiatric component to that because we feel like crap, so we feel like crap. So sometimes do we need to enlist, behavioral health, counseling, that sort of thing to deal with some of those symptoms as well.
Have you made a lot of referrals for mental health or even like substance use?
I personally have not, but I can just see that as a potential issue for sure.
For patients who have like this chronic cough that's going to last a really long time,
Mm-hmm.
a lot of times they come in and they're concerned about it, like it's not going away, what's going on? What do you tell them? What's your talking points for them, especially knowing that this is going to be really long?
Yeah, and that's what I typically start with is, a post-infectious cough, whether it be COVID or RSV or influenza, it's very common that those will last up to several months, which is a normal course of that illness. So first is kind of managing that expectation. Secondly is like with COVID, it could last longer and we don't really know how long it's going to last. Everybody seems to be a little bit different. And then it's a matter of kind of trial and error in terms of therapies to try to help with the symptoms as best we can. So Tessalon, Robitussin, some of those over-the-counter, antitussives that are available, inhaled, medications like Trelegy or Breztri or any other combination inhalers that I tell them it's like, it could help, it could not, we can try it. If it doesn't help, then we're not going to waste our money on it anymore. We're just going to put that aside. But it's something that typically with time gets better. Now, chronic cough, I tell my patients, is the bane of the patient and the pulmonologist because there's so many things that can be contributing to it. So if we're treating some things and it's not working, okay, is this truly, post-COVID chronic cough, or is this chronic cough? And I've got to address this in a different way. So treating chronic cough, like treating reflux, treating postnasal drip, those sorts of things. If we're not targeting those, we should probably try that and see if there's some relief there. What we think, and we're not entirely sure, there's some neurologic component to that cough. Because we know that COVID can affect the nervous system. There's likely, that's the majority of the component of most of these symptoms is a neurologic component. So we try to treat the symptoms as best we can, but also discussing, well, this is going to take some time for sure. If we're still not getting any benefit and we're way down the line, we're still coughing, we've tried everything, that's when it starts time to look out to other options in terms of clinical studies, that sort of thing for chronic cough, which may be helpful. For people with, severe persistent chronic cough, not just for COVID, but chronic cough in general, I've had some success with gabapentin, and that's, working on the neurologic pathway. So that's a potential option. But I would say if we're struggling, we're having difficulty, definitely reaching out to specialists to help out for further evaluation. Looking at lung function testing, looking at a chest X-ray or CT scan, is there something pathophysiologic that's causing the cough that may or may not be related to COVID. But if I've got a post-COVID person with chronic cough and on imaging there's fibrosis, I'm going to treat that different than somebody who's just got the chronic cough. Because now I've got to treat the fibrosis. And that's when we're looking at antifibrotic therapies or in setting of severe fibrosis, referring them over for lung transplant potentially. Especially with the Omicron wave that we had, there seems to be less severe illness and less hospitalization, but I'm seeing more people that are showing up in my office with persistent symptoms. And a lot of it has been primarily people who have a pre-existing lung condition, like asthma, and they had no problems with it before. And then they had COVID, and it may be right away, but it may be, you know, a couple months down the road. It's like, now I'm more short of breath. Now I'm wheezing more. I'm having nighttime symptoms causing problems. So I have seen a good amount of that more recently. Have I seen anybody who have hearing loss? I have not. There's certainly the loss of sense of smell, you know, is a common acute symptom that may persist for a while that typically resolves completely on its own. Same with taste, which those two are linked. Yeah.
There's no questions online.
Okay, good. Excellent questions. Any others? No? Okay. Let's see if that works. There we go. So shifting gears to an update in COPD. So the GOLD guidelines, which get updated fairly regularly, and this is looking at diagnosis, management of COPD. They recently were updated just this year. And one thing that I found happen when I'm in the office and the reps are coming in with their inhalers, you know, they keep talking about, oh, the new GOLD guidelines, you need to be using this. And it's like, did you read the GOLD guidelines? Because I think you're pushing something and, you know, it's not exactly what they're saying, but it fits your narrative. So I wanted to go over that and make sure everybody's up to date. So as you likely know, COPD is a lung condition with chronic symptoms of either dyspnea, cough, expectoration, or exacerbations due to abnormalities in the airways and or alveoli that cause persistent progressive airflow obstruction. So that airflow obstruction is important key. If they don't have obstruction on their PFTs, they do not have COPD. They may have COPD later, but they do not meet the qualifications for COPD yet. And in terms of that obstruction, there are two different definitions that are used. One is the GOLD definition, which is a post bronchodilator FEV1 to FVC ratio of less than 0.7. Or the ATS, American Thoracic Society guidelines, which is looking at that ratio less than the lower limit of normal. And you'll find that on our PFTs that we do in our office. Previously, they did not list lower limit of normal. Now we list lower limit of normal for everything. So most of us in the office will read these based on ATS criteria. And the reason for that is it more accurately diagnoses obstruction at either younger or older age. That strict cutoff of 0.7 means we over or underdiagnose people on either the younger or the older side. So that's why we'll typically read with ATS. We base the severity of obstruction based on the post-bronchodilator FEV1. So if we're greater than or equal to 80%, it's mild, and then going to moderate, severe, or very severe. Speaking on PFTs, it's important to remember that just because they don't have reversibility or a significant bronchodilator response on PFTs doesn't mean they don't get symptomatic benefit from bronchodilator therapy. So somebody who gets albuterol and they only have a 5% change is not significant, but they feel better. That's, you know, a benefit for sure. So it's still recommended that even if they don't have that significant reversibility, that they should get bronchodilator therapy, either PRN or at baseline. So we categorize patients with COPD into now one of three groups, and that's part of the recent GOLD update. So either A, B, or E, and think of E as exacerbations. People who are having a lot of exacerbations fall into that category for the most part. We use number of exacerbations in their past 12 months, and either a CAT assessment, which is a questionnaire looking at symptoms of shortness of breath, or a modified dyspnea scale. And I'm not going to put these up today. They're readily available with an easy search. But we use those to put people into one of those three categories. So if you're having significant exacerbations, which means greater than or equal to 2 moderate exacerbations, they need steroids, they need antibiotic, that's an exacerbation, or 1 hospitalization, you're automatically in category E. Without those significant exacerbations, now we're looking at what's your symptom burden. So category A, less symptomatic, category B, more symptomatic. So based on those categories, then we can determine what's going to be the best inhaled medications for these patients. So there is definite benefit of short-acting bronchodilators, either a beta agonist or muscarinic antagonist, help with both FEV1 and symptom burden. And the combination may be better than either med alone. So that's when we're looking at things like Combivent would be an example of a combined SABA and SAMA. A long-acting beta agonist, long-acting muscarinic antagonist helps improve lung function, shortness of breath, health status, and reduces exacerbation rates. And combination therapy looks like it's better than monotherapy when we look at the literature. In terms of steroids, and this is where the drug reps come in, the inhaled corticosteroid and LABA may help lung function and reduce exacerbations in people with more significant COPD, so moderate to very severe. And triple therapy appears to have beneficial effect on mortality in symptomatic COPD patients with frequent or severe exacerbations. So that's the key there, is the frequent and severe exacerbations. So what do we do to choose an inhaler? So my 2 cents on the subject, it's all individualized. So I'm going to pick an inhaler that A, my patient can afford, B, my patient can use, because there's some inhalers that, if you've got bad arthritis, that sort of thing, is going to be very difficult to use. The Respimats in particular, while they're a great drug, are hard to use for some patients. And then I want to try to have them on the fewest inhalers as possible, help lower their copays. So typically I'll reach for either a LAMA or a LAMA-LABA in those group A or B patients. And then when it's looking into group E, that's when we're looking at the triple therapy with LAMA-LABA and ICS, because there is at least superiority to just the LABA ICS. So your Advair, your Symbicort, your Brio, all those that are just LABA ICS, that's really not encouraged anymore for those frequent exacerbators. It's just not enough therapy for them. So that's where the push to triple inhaled therapy, which you'll hear in the office all the time from the reps, is actually warranted. It's not everybody should be on triple therapy. It's those patients should be on triple therapy. And then it's really important to consider, is there overlap with asthma? Because if we're not treating the inflammatory component of asthma with an inhaled corticosteroid, we're probably doing an injustice to our patients that way. And there's a lot of crossover. So graphically, looking at the groups A's and B's. So A, if they are completely asymptomatic, they have no problems whatsoever, here's your albuterol inhaler, use it as needed. If they've got more significant symptoms, like, yeah, it bothers me, I'm using albuterol, fairly regularly. Okay, now I'm going to add either a LAMA or a LAMA-LABA to them. And then if we're having frequent exacerbations, that's when we're looking at LAMA-LABA and ICS. Now, if I have somebody who comes into my office and they're completely stable and asymptomatic on a LABA ICS, do I change them? No. I typically keep them on their maintenance therapy. As soon as they're having more difficulties, more exacerbations, now I'm going to upscale them to triple therapy instead. Any questions on that? The reps will tell you everybody needs triple therapy. That's what the recommendations say. And the answer is that's not what the recommendations say. So. Other therapies to consider with COPD. So long-term oral steroids, so many side effects, no documented benefit in these patients. They'll swear up and down, I feel better when I'm on steroids. Like, I bet you do. You know, that's the other effect of steroids. It's not affecting your breathing. It's just affecting how you feel. And if you're somebody who's been on steroids for a long, long time, it's going to take a while to titrate those people off, because they will get, you know, some component of adrenal insufficiency if you try to stop them too quickly. So even on lower doses, I've seen it, it's happened. So weaning those patients off, I tell them, you know, my goal is to get you off of steroids altogether. We're going to do it in a stepwise fashion. It's going to take time, but it's going to decrease your complications and side effects down the road. PDE4 inhibitors, people who are frequent exacerbators, this can be helpful if they're still having a lot of exacerbations despite maximal inhaled therapy. And then antibiotics, azithromycin, helps reduce exacerbations as well. So I'll typically use azithromycin 500 milligrams Monday, Wednesday, Friday. If they're still having problems, I'll put them on 250 every day, and that'll be a chronic medication for them. Smoking cessation, smoking cessation, smoking cessation. Every visit, every time, talk about smoking cessation. I tell them it's like gasoline on the fire, and the inhalers are like water. If I'm pouring both at the same time, I'm making no headway. So very critical to bring that up with every visit. Pulmonary rehab is something that's probably frequently underutilized in these patients. Sometimes it's just, and understandably, patients don't want to go into pulmonary rehab twice a week for 3 months and have a copay of, you know, $20 or what have you. It's just not affordable to them. So that's when looking into resources, availability of assistance, that sort of thing could be helpful. At minimum, do something at home in terms of exercise, and it's a focus on cardiovascular type exercise. So treadmill, exercise bike, something lightweight exercises for the upper body. I tell them get some, you know, lightweight dumbbells or even cans of soup, and, you know, do some curls and, you know, shoulder pushes, that sort of thing, because we want to build up those muscles in the chest, which help with breathing when we're using them as secondary muscles. Oxygen therapy for those who qualify. So cutoff is 88% on room air, and they qualify for oxygen. Some people may benefit from non-invasive ventilation at night. So these are people with, again, frequent hospitalization, CO2 retention, you know, putting them on nocturnal ventilation with like a trilogy ventilator or even just BiPAP can be helpful. For some people with significant emphysema, we look at lung volume reduction. Surgery has been the traditional route for that, where they actually go in and lop off the upper lobes of the lung to make more room for the healthier lung below. Endobronchial valves are coming into play more recently. There was a study a few years ago that showed pretty good response. It's kind of been lost in COVID, everything, like everything else. But my anecdotal experience, I've only had one patient who had endobronchial valves for this problem. And I know the folks across the street at the three-letter institution have been participating in a trial for that, and just not seeing the same results as the big national trial that came out. So I think there's potentially, you know, some benefit there, that bronchial valves may be helpful, but they've got a lot of complications associated with them. There's about a 25% risk of pneumothorax after they put in these valves. So that kind of complicates the beneficial side of things, and they may end up needing surgery anyways because of that. Alpha-1 antitrypsin augmentation. So it's really recommended that anybody with COPD get screened for alpha-1 antitrypsin deficiency. Again, something that's probably under-recognized and has a significant benefit in terms of treatment with augmentation. We can arrest the progression of their COPD. So there's some simple screening things that we can do. There's a finger swab, or a cheek swab, or a finger stick test that send it into the company. It's free. They give us a report saying what's the mutation. And then if they have any of the mutations that puts them at risk for deficiency, then you can get a quantitative level of their alpha-1 antitrypsin to see if they're a candidate for augmentation therapy. And that's usually I believe it's a once a month or twice a month infusion that they go through. And vaccinations. So I usually use this time of year to really push vaccinations with all my chronic patients. So making sure you're getting your flu, your COVID vaccine, RSV vaccine for anybody who's over 60 now, definitely pushing that. And then pneumococcal vaccinations as well. Because preventing infections prevents exacerbations, prevents worsening. All right, any questions on the COPD side of things? Triple therapy is great for people who need it, but not everybody needs it. Okay. So lastly, lung cancer screening. So as I mentioned earlier, we're coming up on November, which is Lung Cancer Awareness Month. And we have tools available to us that help us diagnose lung cancer at an earlier stage where it's more manageable and a significant improvement in survivability. So within, it's been almost a decade now, that the Preventative Task Force has been recommending low-dose CT for screening for appropriate patients. And those patients are age 50 to 80. They need to have at least a 20-pack year history of smoking. And they have to be either a current smoker or quit within the last 15 years. So those guidelines recently, and these are the ones that are the newest, but that it used to be, I think it was 55 to 75 and a 30-pack year history. So they've expanded the age group and they've decreased the smoking requirements to qualify. And it's because it makes a big difference in terms of catching cancer. The sad thing is that last year, only 5.8% of eligible patients nationwide were actually enrolled in screening. So we are missing a huge population of patients who would benefit from getting screening scans. The survival for lung cancer has been trending up nationwide, and that's partially because of screening and catching lung cancer early, whether it be through a screening program or through finding things incidentally. Unfortunately, Nebraska and Iowa both fall below the national average in terms of 5-year survivability with cancer. So we've got room for improvement here. Part of it is just willingness to do it in terms of screening. Our screening is a little bit below the national average. There are some states that, like Massachusetts, 18% of eligible patients are enrolled in lung cancer screening. There are some states where it's like 2%. And so we fall just below that 5.8% in terms of our 2 states. Now, I'll show you a little local data for Methodist later that shows that I think we do a great job. And in some ways, we're better than national, but there are definitely places where we can improve too. So the 5-year survival in early stage lung cancer, so stages 1 and 2, basically, is roughly around 61%. The 5-year survival of late stage cancer is 7%. And unfortunately, 44% of cancers are diagnosed at a later stage. And only 26% are diagnosed at an earlier stage. So what we're trying to do with lung cancer screening is stage shift our diagnosis time. So pushing towards earlier diagnosis where we have a significant improvement in survival.
Does insurance cover that screening?
Yes. Yeah. So those preventative task force recommendations are covered by Medicare and private insurance. And I believe Medicaid as well. So what programs do we have in relation to lung cancer within the Methodist system? So we have our low-dose screening program, which I would argue is probably one of the best in the country in terms of the patients that we do have enrolled. The incidental nodule program that we have available. So anybody who gets a CT scan in our system, there is software that looks through that report, catches nodules that are incidentally found on a scan done for another reason, flags it for review. We have our thoracic oncology clinic, so both pulmonologists and thoracic surgeons are there evaluating patients for, we see the people who have a positive screening scan, a positive incidental nodule, refer for either bronchoscopies or surgery as warranted. And then a more recent addition that we have in our system is the robot-assisted navigational bronchoscopy, which is really helping us diagnose cancer at an earlier stage on smaller nodules further out than we've been able to get previously with bronchoscopy. And we recently had our 600th case in the Methodist system. So as you can see, our lung cancer screening scans, this is our local data now, has been trending up. So year to date, we've done over 2,700 screening scans. And year over year, it's just been exponentially growing, which is a great thing. But we can do better. So in the entire US, there's been over 904,000 screening scans through, and this was dates through 2022. And then we had over 2,400. In terms of our comparison and our patient population, so part of lung cancer screening is also smoking cessation counseling. So we have a significantly higher non-smoking rate in our patient population, which I think we do a good job about counseling and getting people to quit smoking when they're enrolled in the program. So we're doing better than the average. And what's even more impressive is the people who remain in lung cancer screening and get their follow-up scans every year. So we have an over 80% retention rate for people who are within the screening program, which is phenomenal. And that really points towards the team that we've got that runs this. They do an excellent job with following up with patients, letting them know what everything showed, communicating with primary care providers, letting them know what shows, and making sure that these people get followed up on to schedule their follow-up scans a year down the road. Because that's one of the hardest things for this type of program is just making sure the follow-up gets ordered and done. Because it's very easy for something that's just done annually to get lost in the weeds. And so with the system that we have set up here, we do a phenomenal job with that. So people who get enrolled typically stay enrolled. This is data for 2022. So through our screening program, we found 19 lung cancers. So that's 19 lives that are significantly improved potentially with screening. Now, unfortunately, several of them were in the later stage, but the majority of patients were actually in early stage cancer where, we may be looking at a surgical cure. Go in, cut it out, we're done. We had, and that just kind of breaks down the diagnostics that we did. So most of these ended up getting referred for bronchoscopy. Some who weren't amenable to bronchoscopy would get a CT guided biopsy. Our incidental program, so any scan that happens in our system gets reviewed, and if there's a nodule, it gets flagged for review. So you can see roughly about the same number of scans in 2021 and 2022 that we did. We found over 800 nodules as a part of that. 700 of them got enrolled in surveillance of those nodules, and then over 140 each year referred to our thoracic oncology clinic for further evaluation. And in 21, we found 42 cancers as part of this incidental program. In 2022, we found 26, and I think we have year to date, we have 16 this year. So we're the only program in the country, or not in the country, locally, that has this software so far. I know it's getting brought up at Nebraska, and I believe CHI is as well, but we're at the forefront of this incidental program. And as you can see, that's 20 cancers that last year that wouldn't have been diagnosed otherwise. And for the most part, were early stages. So this makes a huge impact in survivability for our patients. So we're very, very proud of that incidental program. And I think this is just our incidental program for this year. So this is a case of my patient that was referred to me for an incidental, not an incidental, sorry. This was a screening CT scan that was done. And as you can see down in the right lower lobe, he has this area that was very suspicious. And so with his smoking history and that suspicious nodule, we decided to go ahead and pursue bronchoscopy. So this is our ion navigational robot that we've had for the past, I believe, 2 years, a little over that. And this helps us drive out to a small nodule like that I couldn't have otherwise accessed with traditional bronchoscopy, and certainly would be difficult to get with a CT guided biopsy because there's a lot of lung tissue that needle's got to go through that increases our risk for pneumothorax, that sort of thing. So an important thing to keep in mind, CT guided biopsies, effective, but up to 25% chance of pneumothorax with those. With bronchoscopy, it's less than 3% to have a significant pneumothorax. So if we can do it by bronchoscopy, we like to. The other benefit with bronchoscopy is I can evaluate the mediastinum at the same time, so I can ultrasound and biopsy any of those lymph nodes. If it's CT guided and it's positive for cancer, they may need another procedure to fully stage them. So we can do kind of one-stop shopping with bronchoscopy, which is nice. So when we're in the bronchoscopy suite, and this is me down in the lower left-hand corner, the program, we load their CT scan in, it creates a virtual airway and gives us a pathway to drive all the way out to that nodule. This is the live picture of the bronchoscope as we're going through. And then we can navigate all the way out to this area in question. And then we use fluoroscopy and ultrasound while we're out there to identify the nodule, stick a needle in it, and get a biopsy, which is pretty darn cool. For him, we diagnosed cancer. He was referred for surgery. He's had resection. He's doing well. And so this was, a successful screening program that helped catch an earlier stage cancer for this gentleman. So that's always a big win for us. So how can we improve lung cancer screening? So one is making sure we have an accurate smoking history. It's notorious, not just in our electronic record, but any electronic record, that the smoking history is not entirely accurate. Former smoker, maybe all that's in there. I'll say, well, when did they quit? How much did they smoke? How long did they smoke? We need to get that accurate pack-year history to identify these people and say, yeah, you would benefit from screening. Let's get you a CT scan. We want to counsel our patients when we're doing this. So when we do screening scans, we find a lot of nodules, and I mean a lot, and not all nodules are cancer, especially in this part of the country. We have a lot of granulomatous disease. We have a lot of mucus plugging, that sort of thing. So not all nodules are problematic, but we want to catch them, we want to watch them. So we tell our patients we want to catch the disease sooner, has a better survival, and by enrolling in this program and having to go through a CT scan every year because you're a smoker, it makes you think every time you're going in for that, it's like, maybe I should quit smoking. So there's actually a higher success rate in smoking cessation for people who are enrolled in a lung cancer screening program. Bad side, you find a lot of nodules. There's a lot of false positive scans. So some of these, based on their size, their appearance, we may say, yeah, we're going to watch this. We're going to repeat a CT scan in 3 months. Or we're going to repeat another CT scan in 6 months. Or this is problematic, we should biopsy it. So they're going to get more scans. They're going to get more radiation exposure. We may have an unneeded procedure for a benign nodule, but it's better to diagnose said benign nodule and call it benign and not miss a cancer as opposed to missing the cancer. It's kind of how I sell it to patients, for lack of a better word. So there is a kind of a guideline from the National Cancer Institute that goes over counseling and how to approach this. There's a comparison, and I can actually pull this up real quick. Maybe. Yeah, there's not a virus, it's fine. So this is just a document. Oh, I lost it. But basically, it's a document that goes over kind of the pros and cons of either a CT scan or a chest X-ray in terms of screening. You can go through that with your patient, talk about, you know, false positives and that sort of thing, and just give them something to give them to look at and say, here, this is why I'm recommending do this, because this is why a CT scan is better than a chest X-ray, basically. Because really small nodules, I'm probably not going to see on an X-ray. It's going to hide. And then what we're doing as a system is we're trying to improve our electronic record to try to flag these patients better. To say, hey, this patient qualifies for lung cancer screening, hasn't had a CT scan in a year. Maybe we should get them enrolled, sort of thing. So hopefully we can make some headway there in the next, months to years. So. We have a really growing team. So these are all of our pulmonologists in our system. A couple of new faces here locally. Molly Bretan and Rosina Schiff have both joined us this year. We have another pulmonologist who's joining this month. And then one more who's going to be joining us next year, have all signed. And then we have our Council Bluffs group and our Fremont group. So we are all readily available. If there's any questions, issues, have problems getting a patient in to be seen or needs to be seen urgently, don't hesitate to reach out to us so we can help them out. Any questions about anything? What are thoughts on patients with known high radon exposure and cancer screening, or people who have high radon levels? So radon is the number 2 cause of lung cancer in the United States. Unfortunately, it's not included in terms of recommendations for screening. So it's really only smoking cessation that's recommended for screening guidelines, or not smoking cessation, significant smoking history for screening. I don't know if radon is ever going to be something that's included in that. It's one of those things that's so ubiquitous. Pretty much anybody who lives in this part of the country has some radon exposure in their house. May not meet their, the cutoff criteria when they do the testing, but there's some radon exposure for sure, and that would just really explode the number of patients who would qualify, and then you'd have a lot more false negatives. So that's the biggest risk to consider with the screening program, or a false positive scan. So I've got a nodule that leads to a biopsy that leads to a complication that was a benign process. So I think the total number of cancers that you would actually catch by including radon in lung cancer screening would probably be so low that the risks would outweigh the benefits of adding those people into a screening program, which is likely why it's not recommended at this time. Good question. Mostly it was location. So location and size, certainly. So the further out, the more difficult, because we could only drive out to as far as we could see. We did have some other, navigational tools that have been available in the past. One is called Super D, which was an EM field navigation software that was glitchy. It was effective for the most part, and again, for bigger nodules, but for smaller ones like a centimeter in size or less, it would still be kind of difficult to drive out to potentially, and it was blind. So that software, we put a probe into the airway and we drove it out purely based on computer screen and what the EM field was telling us to navigate out to. With the robot, I can actually see as I'm driving out all the way to that area in question. So the accuracy and fidelity of it is better that way. But in terms of just non-navigational bronchoscopy, this thing would have to be, at least 1.5 centimeters or better, and very close to and within an airway, really, for me to be able to biopsy it with just traditional bronchoscopy. With this, now I can say, okay, this isn't in an airway, but it's by an airway. I can drive out to that, park my catheter, and stick a needle through the airway and into the nodule, where I wouldn't have been able to do that before. Less so. So I think that's one of the things that kind of fell behind with COVID. There's a huge thing with EVALI, vape-induced lung injury, before that. And yeah, it caused severe disease. I saw hospitalized patients that were, borderline transplant. And some of them would refuse to quit vaping. So there is definitely a lot of lung injury that can happen. So I counsel people regularly if they're vaping, it's something they really need to work on quitting. There was, previous to the vape lung injury kind of epidemic, for lack of a better word, there were some systems that were using vaping as a smoking cessation strategy. And the NIH was actually one of them who was saying that, yeah, that's an option in terms of smoking cessation, with the goal of quitting vaping too. But with the severity of lung injury from vaping, that's really fallen by the wayside. So it's really not recommended as a smoking cessation tool anymore. I tell people there are better ways to inhale nicotine that don't have all the other stuff that come with vaping, because they do have nicotine inhalers that you can use as a smoking cessation tool. So if you're fixed on that inhalation, that oral fixation with smoking, then maybe a nicotine inhaler is a better way to do it. But there are better options in vaping for sure. For the people online, that was a question, how should we be screening for vaping? And so there's a way to document it. There's not a really good way to quantify it like there is with cigarettes. So I can't put a pack year history on vaping. It's a binary, yes or no. So I would argue if it's a yes, and it's like, okay, we need to be counseling you to not vape. What I'm not sure of, and I'd have to ask the coders, is that counseling a billable encounter? Because smoking cessation is. So with the right CPT code, it has to be cigarette nicotine dependence. You can, bill for counseling time 3 to 10 minutes or greater than 10 minutes of counseling on top of your office visit. But I don't know in terms of qualifications for vaping if that falls into that line or not. It should, and because it's classified as a tobacco product, even though it's not tobacco. So I would think it should qualify for that, but I'm not 100% sure on that. So I think as long as there is some form of documentation, the smokeless tobacco is going to be more chew. Snuff or chew is really what that's targeting. And those are people, we need to be really fixated on oral cancer screening, that sort of thing, for sure. But if there's not a vaping, choice that's there should be, and I'm sure there is an upgrade that can include that, but at least document it in the comments so it's documented somewhere is the way to go. So the vaping side of things, and part of it's because vaping is such a newer thing for the most part, that side hasn't really caught up with the lung cancer screening side of things. So the little data that we have in terms of vaping, there is a lower percentage of the carcinogenic toxins in the vapor. Because it's not smoke, it's vapor. So there's a lower percentage of that. So there's probably, and that's a big probably, lower risk of lung cancer with it. But the irritation and damage to the tissue can certainly cause other problems. And it's usually more of an interstitial lung disease that people who are vaping are at risk for, as opposed to cancer. But the same stuff that causes cancer that's in cigarette smoke is in the vapor from a vape just at a lower concentration. So I don't think they've teased out that there's a significant higher cancer risk. I know it's something that's being looked at, but it just hasn't. If they're just a vapor and they've never smoked cigarettes, they wouldn't qualify for the low dose screening scan at this time. In the national data, there was more association of ILD with cannabis associated vaping as opposed to nicotine, just nicotine. But there's definite, people who never did cannabis who developed interstitial lung disease from vaping. So it's the toxins that's in the vape that are there, and that's part of the regulatory problem that this industry has had. That there just isn't a regulation. There's so much variation and stuff. So it's more of an interstitial lung disease, and it's typically heavier smoke, heavier users that would run into that problem. But I don't think there's necessarily a set duration of time or anything that it's been identified. A lot of that stuff really, again, kind of fell off during the COVID pandemic because all the research and everything got focused on that, and some of those other things kind of fell by the wayside. So I would imagine, there's going to be more stuff coming out on that as time goes on.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.